In 2015, there were approximately 150,000 new HIV infections among children, with an estimated 1.8 million children under the age of 15 living with HIV/AIDS. Transmission of HIV from mothers to their infants can be prevented through the use of antiretroviral drugs, safe delivery practices, and safe infant feeding, all of which are provided through prevention of mother-to-child transmission of HIV or PMTCT programs. These interventions can reduce the chances of HIV infection from about 4 out of 10 to less than 1 out of 10, depending on which interventions are available. However, even within good PMTCT programs, some infants still become infected with HIV during pregnancy, during delivery, or during breastfeeding, but this is rare. For infants infected with HIV, rates of death are very high if untreated. Therefore, early infant diagnosis of HIV, or EID, allows children to receive HIV treatment and care before they get very sick and to remain healthy despite having HIV. Unfortunately, only 51% of HIV-exposed infants in the 21 highest burden countries received a test by 2 months of age in 2015. There are 2 main types of tests for diagnosing HIV. One measures HIV antibodies and the other measures presence of the HIV virus. HIV antibodies are typically a sign of the body's response to HIV, and they are measured using the rapid HIV test. But mothers also pass these antibodies onto their babies during pregnancy and delivery. The mother's antibodies may be detected in an infant for up to 18 months after birth, but these antibodies do not mean that the baby is infected with HIV. This means that early diagnosis of HIV in infants cannot be done using the standard rapid HIV tests that are used for adults, because these tests detect HIV antibody. A positive HIV antibody test in an infant younger than 18 months old cannot tell us if the antibodies detected are the ones passed from the mother or if the baby has become infected with HIV and is making its own HIV antibodies. A laboratory technique called polymerase chain reaction testing, or PCR, makes it possible to diagnose infants as early as day 1 of life by detecting part of the virus. The World Health Organization, or WHO, recommends that all HIV-exposed infants receive a PCR test at 4 to 6 weeks of age. In 2015, the WHO recommended that countries also consider providing HIV testing to infants at birth in addition to HIV testing at 4 to 6 weeks of age. All HIV-exposed infants should have a final HIV test at the end of the breastfeeding period. You should follow the national guidelines for your country about when to do PCR and repeat HIV testing for HIV-exposed infants. In the past, PCR testing required phlebotomy, drawing blood from the veins, which is not easily done on young infants. PCR testing is now being done using dried blood spots, also called DBS, which are easier to collect in infants. Through the collection of an infant's blood on specialized filter paper, you are taking the first critical steps to make early infant diagnosis of HIV possible. Countries are developing and implementing guidelines to provide viral load monitoring to their HIV-positive patients on ART, including infants and children. Some of the machines used to measure viral load will be able to process DBS. The techniques you will see here can also be used to collect a DBS sample from an infant for viral load monitoring. Only a few drops of blood are needed. They can be obtained from a simple prick of the infant's heel, toe, or finger. This is easier on the infant, the parent, and you. The blood spots can be easily dried, stored, and transported to the laboratory for analysis. In this short film, we will demonstrate the skills you will need to collect high-quality DBS samples. Remember, a test result is only as good as the specimen collected. We will show you how to 1. Gather the supplies required for DBS collection. 2. Collect DBS samples. 3. Dry, package, and if necessary, store DBS samples properly. 4. How to tell the difference between a valid and invalid DBS. And 5. ensure that all DBS cards are properly labeled and that specimen logs are kept accurately. Regardless of the age of the patient or location from which the sample will be collected, the preparation steps for collecting the sample will remain the same. We will begin our training by watching a nurse gather her supplies for a DBS collection. Keep in mind that the supplies used by your program may look slightly different from what is shown here. Your program may be using pre-packaged bundles with all the supplies needed for DBS collection. If your program does not have these bundles, you will have to gather the items separately. First, you will need a sterile, disposable, blade-style lancet or glucolate. The blade should be 2.0 millimeters long or less and 1.5 millimeters wide or less. This puncture depth is critical for all children, especially small babies. A 2 millimeter lancet is the correct length to puncture safely without damaging bone. The lancet should be held firmly against the heel without pushing down. Most lancets come with a protective guard that must be removed before the blade can be activated. Once the guard is removed, the lancet should be used immediately. It's critical that the blade cover be disposed of immediately in regular or biohazard waste to prevent choking. These sterile lancets or glucolates should be used one time only, then properly disposed of. Next, you will need skin disinfectant. The DBS collection bundle includes individually packed gauze swabs with alcohol. If you are not using a bundle, you will need gauze or cotton wool moistened with alcohol or spirits. Gloves with no powder are best because powder can interfere with PCR testing. If your gloves have powder, you must wash it off before touching the baby's foot or the DBS card. It's important to have a new, clean pair of gloves for each patient that receives a test. Finally, gather your necessary lab forms, a DBS collection card, and a pen. To take a DBS sample, it is important to use specialized collection cards. These are made of an absorbent filter paper and are specifically made for blood collection. The area for the DBS may be perforated or marked with lines. These lines and perforations show where the DBS needs to be collected. You will need to be sure your DBS are centered and filled to the line or perforation on the card. The chart shows the location for where the samples could be collected based off the infant's age and weight. Heel pricks work best on infants between 1 and 4 months old or less than 5 kilograms. Toe pricks should be used for infants 5 to 9 months of age or less than 10 kilograms. Finger pricks should only be used for infants 10 months or older and who are more than 10 kilograms. Now we will see how to take blood samples from infants. We will start with a small infant. Watch as this nurse collects a DBS from a young infant. It will be easiest for you to take DBS when the parent is seated at about your waist height. Take the time and care to help the parent get onto the table safely. Use a pen to complete the laboratory requisition form as per instructions in the National Guidelines for HIV Diagnostics in Infants. If the information is not complete and correct, the lab may reject the DBS. When the lab rejects the DBS, this means that testing is not performed and recollection may be required. After confirming this is the correct child to be tested, it is important to set the parent at ease about how the DBS will be taken and to ask for their help in making the procedure quick and easy for the baby. Here, the nurse is showing this mother how to warm her baby's foot. Blood will flow easily to the warmed area and can be taken with minimal time, trauma, and effort. If you are taking the DBS in colder weather, you can soak the baby's foot in warm water or use a nappy soaked in warm water to warm up the foot if necessary. While the mother warms the baby's foot, the nurse can prepare to take a DBS by thoroughly washing her hands before putting on new gloves and assembling her supplies. Gloves in DBS collection bundles do not have powder and can be used straight away. If your gloves have powder, wash your hands with gloves on to remove the powder. The nurse is labeling the DBS card on a clean surface with the appropriate identifying information and the date of the test. She is also taking care not to touch the circles on the card or anything else, as touching the circles can contaminate them and affect the test result. When taking DBS from a heel prick, positioning the baby properly with his or her foot down is important for a quick and clean collection. Usually the best way to do this is to ask the mother to put the baby on her shoulder, putting one arm under the baby's bottom. By holding the baby firmly under the bottom, the mother can help you control the movement of the child, making the procedure safer and more accurate. As you can see here, the nurse has selected where she will prick the baby's foot. For small infants up to about the age of 4 months and up to 5 kilograms, pricking the side of the heel works well. Do not prick the back or bottom of the heel where the bone is. The area will then need to be cleaned. Wait 30 seconds for the area to dry completely because disinfectant left on the foot could contaminate the specimen. While waiting for the area to dry completely, uncover the lancet blade and dispose of the guard as soon as possible to prevent choking. The lancets should be used immediately after uncovering the blade. Gently squeeze and release the infant's lower leg and foot until it looks like blood will easily come out when the prick is made. The heel should be warm and pinkish in color. Do not apply pressure too close to the prick. Press the lancet firmly on your chosen spot while holding the foot steady. Then depress the trigger so the blade punctures the heel. Wipe off the first drop of blood with the dry gauze or cotton wool. This first drop is not good for testing because it contains tissue fluids. Remember to properly dispose of the lancet in the sharps container and the gauze in a biohazard container. Then let a second, large drop of blood form. You may gently squeeze and release the infant's lower leg and foot to increase bleeding. It is very important not to squeeze right around the puncture site, as this will cause you to get tissue fluid instead of blood and the lab may not get a good result. Now gently touch the filter paper to the large drop of blood in the center of a marked circle. Do not press the paper against the puncture site or heel. Let the blood soak through and completely fill the circle. For each circle, squeeze the foot until the drop forms. Collect the drop on the filter paper. Release the foot briefly to allow for blood to refill. Reapply pressure until a drop forms. Collect on filter paper until spot is complete. Don't move on to the next spot until each spot is filled completely. Be patient. This process takes more time for some. Try to collect 5 full spots. If this is not possible, at least 3 full circles are recommended. A circle is full once the blood has reached the marked line or perforation. We will review valid and invalid DBS cards in detail in a few minutes. But you may notice that, in this example, not all 5 spots are perfectly collected. However, there are 3 circles properly filled. So this is a valid DBS card. Filling 3 quality circles is better than 5 poor quality, half-filled circles. To care for the puncture site, press gauze or cotton wool over the wound until it stops bleeding. A bandage is not needed if the bleeding has stopped. Here, the nurse is asking the mother to keep the gauze over the baby's wound. Be sure to check the puncture site to make sure the bleeding has stopped before the baby leaves. Now, let's see how to take a DBS from a larger infant. When taking a DBS from a larger infant, the procedure is much the same, but you may have more success pricking the toe instead of the heel. Toe pricks work best for larger infants who are about 4 to 10 months old or who weigh more than 5 kilograms. The initial steps will be the same as for a smaller infant. The nurse will collect the necessary supplies. She will then help the parent and baby onto the table safely, counsel the parent on the procedure, and demonstrate how to warm the foot. Then she will complete patient information on the DBS lab requisition form. The nurse will wash her hands and put on gloves. Be sure to complete the appropriate identifying information and the date of the test. Take care not to touch the circles on the card with your fingers or anything else. For DBS collection from the big toe, ask the mother to help you position the baby with the foot hanging down so you can easily access the toe. Ask her to hold the baby up over her shoulder with one arm under the baby's bottom. By holding the baby firmly under the bottom, the mother can help you control the movement of the child, making the procedure safer and more accurate. The nurse has selected where she will prick the baby's toe. The best place to prick is the side of the big toe. Use only a 2 mm lancet and take care not to prick the very end of the toe where the bone is close to the skin. Clean the area selected and allow it to dry completely. While waiting for the area to dry completely, uncover the lancet blade and dispose of the guard as soon as possible to prevent choking. The lancet should be used immediately after uncovering the blade. Hold the baby's foot firmly with one hand and press the lancet on the toe before depressing the trigger. Note how the nurse has wiped away the first drop of blood because it also contains tissue fluids that will not give a good test result. Remember to properly dispose of the lancet in the sharps container and the gauze in a biohazard container. Now the nurse is collecting the blood spots by touching one drop to the center of each marked circle and letting it fill the entire circle. Squeeze the foot until the drop forms. Collect the drop on the filter paper, release the foot briefly to allow for blood to refill, reapply pressure until a drop forms. Collect on filter paper until spot is complete. Don't move on to the next spot until each spot is filled completely. Ideally, try to fill all 5 spots. Filling 3 quality circles is better than 5 poor quality, half-filled circles. Notice how the nurse is applying light pressure to the whole foot and not squeezing the place where the toe was pricked. Take care not to hold the foot too tight as the baby may then resist and struggle. By using a gentle but firm grip, you will help the baby be more at ease. A circle is full once the blood has reached the marked line or perforation. After you have finished taking the sample, elevate the puncture site and apply gentle pressure with gauze to stop the bleeding. A bandage is not needed if the bleeding has stopped. Be sure to check the puncture site to make sure the bleeding has stopped before the baby leaves. You have now seen a DBS collection by heel prick and a toe prick. You may also need to take DBS by finger prick. The basics of taking DBS by finger prick are the same as heel and toe pricks. Finger prick is only recommended for infants 10 months or older or more than 10 kilograms. Infants will need DBS for HIV diagnostic testing until 18 months of age. After 18 months of age, children can be diagnosed using a rapid test. The initial steps will be the same as for a smaller infant. The nurse will collect the necessary supplies. She will then help the parent and the baby onto the table safely, counsel the parent on the procedure, and demonstrate how to warm the hand. Then she will complete patient information on the DBS lab requisition form. The nurse will wash her hands and put on gloves. Be sure to complete the appropriate identifying information and the date of the test. Take care not to touch the circles on the card with your fingers or anything else. Ask the mother to help you position the baby with their fingers pointing down. At this age, most children can sit on their mother's lap while you take the DBS. You can also try to have the mother hold the baby in her arms with his or her right arm behind the mother. Remember to have the mother warm the baby's hands and fingers. If the baby's hand is cold, you can also soak the hand in warm water or use a nappy soaked in warm water to warm the hand. If the child is not cooperative, you may need to ask the mother to put the child's legs between her legs and hold the child's belly, chest and right arm with her arms. As you can see here, Nurse has selected where she will prick the baby's finger. The best finger to choose is the ring finger or middle finger of either hand. Select the lateral side of the ring or middle finger. Do not prick the tip or very end of the finger where the bone is close to the skin. The thumb is not recommended because it will be the most painful. The area will then need to be cleaned. Wait 30 seconds for the area to dry completely. While waiting for the area to dry completely, uncover the lancet blade and dispose of the guard as soon as possible to prevent choking. The lancets should be used immediately after uncovering the blade. Note how the nurse is using her hand to hold back the baby's other fingers. She is holding the hand firmly and pressing the lancet into the finger before depressing the trigger. Wipe away the first drop, which contains tissue fluids. Remember to properly dispose of the lancet in the sharps container and the gauze in a biohazard container. Taking blood spots from a finger will be easier if you can hold back the baby's other fingers as you apply very gentle pressure to the whole hand. Hold the finger down to put the drop directly on the card. If your first drop is too small, you may put additional drops directly on top of the wet spot until the spot is completely filled before you move on to the next spot. To collect the next drop, release the pressure on the hand briefly to allow for blood to refill. Then reapply pressure until a drop forms and collect on filter paper. Fill each circle by touching the drop of blood to the center of a marked circle on the card. Fill each circle completely before moving on to the next circle. Try to fill all 5 spots, but if you can't, filling at least 3 circles is recommended. A circle is full once the blood has reached the marked line or perforation. To care for the puncture site, press gauze or cotton wool over the wound until it stops bleeding. A bandage is not needed if the bleeding has stopped. Be sure to check the puncture site to make sure the bleeding has stopped before the baby leaves. Here are examples of correctly collected DBS samples with all 5 circles properly filled. Now that we have seen examples of taking DBS from heel, toe, and finger pricks, let's discuss the handling of specimens in preparation for transporting to a laboratory for testing. After DBS has been collected, it is important to handle them properly so they can be transported to the laboratory facilities for accurate testing. After DBS collection, bring the card to the area set aside for drying. The cards should be set in drying racks horizontally and protected from sunlight, dust, and insects. Leave them at room temperature for a minimum of 4 hours or overnight, 24 hours maximum. When drying specimens, don't expose them to heat or direct sunlight. Store them in plastic bags. Stack them against each other. Let them touch other surfaces where water or debris can contaminate or render the specimens invalid. If a card has not been dried correctly and completely, it may not be able to be tested. Also, remember to keep the lab forms with the DBS cards. If you also collect DBS samples for viral load, VL, make sure not to dry EID samples and VL samples on the same rack. Putting both DBS types on the same rack can lead to contamination and potentially false positive results. Label each rack as VL or EID. Once the DBS are completely dry, prepare them for transport. The DBS need to be separated so that the blood spot cards do not touch each other. If the DBS touch each other, blood may be transferred from one card to another, leading to incorrect results. Each DBS card must be completely separated by glossine paper or glossine envelopes. When using glossine paper or envelopes, put 5 to 10 individually wrapped DBS cards into a sealable plastic bag and add 10 desiccant packets to the bag. Place a humidity indicator in the DBS bag. The desiccant packets will work to absorb any moisture in the bag, keeping the cards dry. Press excess air out of the bag and seal. If the packet is not going to the lab that day, leave it in a cool, dry place until it is ready to be transported. Avoid leaving the DBS in a vehicle, as sun and heat will deteriorate the DBS. As you send out DBS for analysis, it is critical to properly label and document all the samples so that the results will be useful. Be sure you have completed all paperwork necessary to track each DBS. Place all of the lab forms and the plastic bags of DBS into the shipping envelope. Be sure to label each shipping envelope with your clinic name, infant DBS specimens, the date you are sending the specimens to the lab. Let's take a moment to review the information we've covered so far about taking and handling DBS. We have discussed the materials necessary for collecting DBS. We have covered 3 different ways of taking a DBS specimen directly from an infant. And we have provided instructions in handling and drying specimens and preparing them to be sent to laboratories. Hopefully, you are already feeling well equipped for your role in collecting DBS specimens for infant screening. Besides collecting and handling specimens properly, you need to prevent problems to make sure each test result is as accurate as possible. Here are a few pointers. First, keep accurate records. The most common reason the lab will reject a DBS is labeling errors. The lab cannot test a specimen if there are errors in labeling. Be sure all DBS cards are labeled, laboratory requisition forms are complete and correct, and that specimen logs are kept accurately. Second, handle and dry the fresh samples correctly. Third, prevent collection problems which can lead to unusable specimens. Here are a few common problems and reminders about how to avoid them. This sample has yellow rings around the blood. This may have been caused by contamination of the specimen by the disinfectant. To prevent it, let the alcohol dry completely before puncturing the skin. If you are using betadine, detergent, or cleaner other than alcohol, wipe it off completely before taking the sample. Another possible cause is tissue fluids in the blood. You can avoid this by not squeezing the area around the puncture wound. These yellow rings mean the sample will not be tested. A problem can also arise from scratching the filter paper. To prevent this, don't scratch or dab blood on the filter paper surface. Using too little blood also results in an untestable sample. If one of your drops is too small, you can put another drop directly on top of the wet drop until the spot is completely filled, before moving on to the next circle. If you cannot get large enough blood spots, the infant's foot may be cold. You may not be squeezing enough, or you may need to choose another site and prick the infant again. If a new drop of blood is put on top of a dry drop, the spot will be layered and will not be testable. To avoid this, do not add a new drop to a drop that is already dry. If the blood spot is not centered in the lines or perforation, it may not be testable. If one of your drops is too far outside the lines, move on to another circle. If the infant is moving too much, it will be difficult to direct the blood to the card. Be sure you have taken the time to show the caregiver how to assist you by holding the patient firmly and safely. High humidity can interfere with the quality and accuracy of the test results. If there is an indication of high humidity, it is recommended that you remove the old humidity indicator and desiccant packs and replace with new desiccant packs and a new humidity indicator. And remember, you should put 10 desiccant packs into the plastic bag with 5 to 10 individually wrapped DBS cards. Be sure to seal the bag by pressing out all of the air. In this video, you've seen how to collect a quality DBS that can be used for infant HIV virologic diagnosis or for infant viral load monitoring as it becomes available in your country. In summary, you've learned how to gather the materials necessary for collecting DBS, fill in the information on the DBS card and laboratory requisition form completely and accurately, select the safest area for puncturing an infant's skin, puncture the skin with a sterile lancet while wearing gloves, apply the proper pressure to a child's leg or hand to promote blood drop formation, wipe away the first spot which contains tissue fluids, collect at least 3 high-quality spots on the DBS collection card, Dry DBS specimens. Packaged DBS specimens for shipping and storage. The early diagnosis of HIV for infants has medical and psychological benefits for babies, their families, and the clinicians who care for them, as a delay in the initiation of treatment can lead to a greater risk of serious illness and death. Mothers and clinicians who have used PMTCT interventions during pregnancy, delivery, and breastfeeding can feel proud of what they have accomplished to protect these babies. Most babies will test HIV negative at 4 to 6 weeks of age. It is recommended that HIV-exposed breastfeeding infants receive HIV serological testing or rapid testing at 9 months of age. Infants who have reactive serological assays at 9 months should have a virological test to confirm the HIV diagnosis. Breastfed infants with a negative serologic test at 9 months should be tested again at 18 months or 3 months after they have been weaned. Serologic tests should only be used to diagnose HIV infection in infants aged 18 months or older. This means that you may be collecting DBS samples for HIV diagnosis from HIV-exposed infants younger than 18 months. Guidelines on infant testing vary slightly from country to country. You should follow your national guidelines for infant testing. Countries are also implementing guidelines for viral load monitoring for patients on ART, including infants. Your Ministry of Health will provide more information on the guidelines and availability of this service. Babies who test positive for HIV should have the opportunity to receive early treatment, which will help them grow up as healthy as possible. The earlier the treatment starts, the brighter the future for these children. All infants who have a positive HIV test should have a second sample sent for confirmation. However, HIV treatment should be started immediately and should not be delayed while waiting for the results of the confirmatory test. After HIV test results are given to caregivers, families and clinicians can turn their focus to building safe and healthy futures for all children affected by HIV. We hope this video has been helpful and informative to you. By properly collecting DBS samples from infants, you are making a difference in the lives of children who can be tested and treated for HIV when they are still very young. Thank you for your part in helping children live healthier, longer lives.